Hello again, this will be part 4 of our neonatal review questions. So we'll start out with question 21. A 2-month-old black male infant is admitted for RSV infection. Baby was born at term via spontaneous vaginal delivery. Prior to discharge, it comes to your attention that the infant's hemoglobin has dropped to 10.1 grams per deciliter from 14.5 grams per deciliter at age 2 days. Peripheral blood smear is performed and is unremarkable. Physical examination is unremarkable. Which of the following is the most likely cause of this child's anemia? A. Sickle cell disease. B. Alpha thalassemia. C. Physiologic anemia of infancy. D. RSV infection. Or E. Transient erythroblastopenia of childhood. So I'll give you some time to pause it here if you need some more time. And the answer to this question is C, physiologic anemia of infancy. So this child has a normal peripheral blood smear. Sickle cell disease is always something that we're concerned about, particularly in African Americans. However, this child does not seem to have sickle cell disease, considering that we have a peripheral blood smear that's unremarkable, an examination that's unremarkable, and so that's unlikely. And then the same goes for alpha thalassemia, given that the smear is unremarkable. RSV infection is not going to cause anemia, and then transient erythroblastopenia of childhood is something that happens later on in life, usually around 1, 2, 3 years of age. So physiologic anemia of infancy is the correct answer. It's common, and this is the correct answer. So physiologic anemia of infancy tends to happen within the first week of life. There's a drop in hemoglobin, and this is a normal response to the increased oxygen availability as the baby begins to breathe on his or her own. So since the baby has access to more oxygen, baby's getting more oxygen breathing than the baby got through the placenta. That increased oxygen availability is going to downregulate erythropoietin, and as a result of that, there's going to be less red blood cell formation. And it's less red blood cell formation relative to red blood cell degradation, hence you get a lower hemoglobin concentration. Now, as that hemoglobin concentration drops, it reduces the oxygen supply, and erythropoietin will go back up. So this is just a normal response to transitioning from fetal to infant life, to adult life. So when the oxygen supply drops below the oxygen demand, and usually that's around 10 to 11 grams per deciliter, erythropoietin will rise and stimulate hematopoiesis, and typically this occurs around 8 to 12 weeks in the term baby. Now, if the hemoglobin is really significantly low, and by that I mean 8, 7, 8, even 9, then you might want to think of other things. Usually the hemoglobin of physiologic anemia of infancy is not going to go much further than 10 to 11 grams per deciliter. This process is typically asymptomatic and inconsequential. However, in babies that have a coexisting anemia, a pathologic anemia, and then they have the physiologic anemia added on to that, then you can get symptoms. So if a baby has a coexisting hemolytic anemia, such as sickle cell disease or Rh incompatibility, then that anemia can be exacerbated and lead to symptoms. Also, in preterm babies, the drop is going to be quicker. It'll happen earlier on, and it'll also be more precipitous. And so you should expect that in preterm babies. This can also lead to symptoms, even though the pathology behind it is still the same, and there's really no other process behind it other than this physiologic anemia of infancy. You can get symptoms in preterm babies because the drop is more precipitous. If anemic symptoms are present, then you can do a red blood cell transfusion if necessary, but usually that's not necessary in these cases. Question 22. A G4P3 mother delivers a term baby weighing 5 pounds 4 ounces. APGARs are 7 and 9 at 1 and 5 minutes. On nursery examination, 12 hours of life, you note a small baby with a head circumference less than the 3rd percentile. There's mild jaundice and scleral icterus. Labs are performed and reveal a total serum bilirubin of 6.1 with a direct bilirubin fraction of 3.7 milligrams per deciliter. At 18 hours of life, you're called to the nursery for an apparent seizure which spontaneously resolves. MRI is performed and reveals diffuse intracranial calcifications. Based on the presentation of this infant, which of the following treatments will be most beneficial? A. Spiramycin, B. Pyrimethamine and sulfadiazine, C. Levetiracetam, D. UV phototherapy, or E. Ganciclovir. All right, so 5-second warning. And the answer here is B, pyrimethamine and sulfadiazine. So you have a child here with the stereotypic presentation of congenital infection. That is, that the child is small for gestational age. Term baby should not be 5 pounds 4 ounces. Appeared relatively healthy at birth. However, you note a small head circumference. That's also somewhat common with babies that have congenital infections, intrauterine growth retardation. And then also this jaundice and scleral icterus is something that you tend to see in congenital infections. When you look at the bilirubin, you note that this is a conjugated hyperbilirubinemia, in that the direct bilirubin is more than 20% of the total serum bilirubin. And so from that, we want to know what kind of infection this is. Now, normally we have mothers who get those antibodies checked, and so we can generally predict what it is based on the mother's labs. However, on the USMLE, you're not always going to have that because that pretty much gives the answer away. So anytime you have a baby that has a suspected congenital infection, if it's not clear right away, you should consider getting an MRI, and certainly you're going to get an MRI for this baby because there was an apparent seizure. The MRI is going to be very useful for differentiating the diagnosis here, and when you see that there are intracranial calcifications, that is practically diagnostic for congenital toxoplasmosis. And so the treatment for congenital toxoplasmosis is pyrimethamine and sulfadiazine. Now these other answers, spiramycin, this would be something that you would give to a mother who has possibly been exposed to toxoplasmosis. But you give this to the mother when she's pregnant with the baby, and that reduces the chance of passing on the toxoplasmosis and preventing this situation. However, spiramycin doesn't do anything for the baby once the baby's born. You'll have to give pyrimethamine and sulfadiazine. Levetiracetam is a medication given for seizures. That's not going to be appropriate in this baby. We need to treat the infection. UV phototherapy is not done for direct hyperbilirubinemia. It is really reserved for unconjugated hyperbilirubinemia. And ganciclovir is not indicated in this case. This is for viral infections. Congenital toxoplasmosis is an infection with the protozoa Toxoplasma gondii, which is acquired through acute maternal infection. So infections in immunocompetent adults are usually subclinical, and that is what makes this a problem, because if a mother is exposed to toxoplasma, usually via cat feces, possibly via undercooked meat, we're not going to necessarily be aware because adults typically don't show, or even children don't show signs of this infection. And so really what we have to do is preventative management of the mother, which is to avoid cat feces, avoid cat litter, and also avoid undercooked meat. And if there is a possibility of exposure, like I said, we can give her spiramycin. Fetal damage is most likely if the infection is acquired during the 2nd through 6th months of gestation, so in that 2nd trimester period. Manifestations of congenital toxoplasmosis are very similar to what we see with some of the other congenital infections, so that can include intrauterine growth retardation, small for gestational age, jaundice, hepatosplenomegaly, rash, hydrocephalus, microcephaly, seizures, cataracts, chorioretinitis, and visual impairment. 70 to 90% of infants that actually do have congenital toxoplasmosis are either asymptomatic or undiagnosed at birth, but they can go on to develop later sequelae, which can include learning disabilities, mental retardation, and visual impairment. So it's imperative that mothers are not exposed to these risk factors, and if they are, that we treat them during their pregnancy. The diagnosis for this is going to be toxoplasma titers that can be obtained from the blood and from the CSF. You'll want to get both. And then you'll also get an MRI, and the MRI will show diffuse intracranial calcifications. So you should, with congenital toxoplasmosis, you should word associate diffuse intracranial calcifications. When you hear diffuse intracranial calcifications, the very first thing you should think of is congenital toxoplasmosis and vice versa, because this is something you will be given on the test. And they'll expect you to know that this is congenital toxoplasmosis, and they'll expect you to know how to treat this. You'll also want to send these babies off to an ophthalmologist or an optometrist to do an ophthalmologic exam, because remember, chorioretinitis is a possibility as well as cataracts. The treatment is pyrimethamine and sulfadiazine. Along with this, you can give leucovorin. And if the mom, as I mentioned, were to be exposed to toxoplasmosis, or if, for instance, she works in a high-risk environment like a veterinarian's office, she can be given spiramycin to reduce the risk of transmission. So here are the diffuse intracranial calcifications. You know these calcifications, and they're just everywhere. And this is different from the periventricular calcifications, which we will see elsewhere. I think I have a question on that. If not, just go back to my lecture on neonatal infections. But I don't want to give the answer away right now. Okay, question 23. A 3-week-old baby girl presents with her mother complaining of progressive jaundice. Baby has progressive jaundice. Mom says her wet diapers have been dark and her stools have been gray in color. Physical exam is significant for jaundice and scleral icterus. Faces are normal. Total serum bilirubin is 9.5 milligrams per deciliter. Direct bilirubin is 6.2. Elk phos and GGT are both elevated. Sonography is performed and is negative for masses and cysts. Which of the following is the best next step in diagnosis? A. MRCP, B. ERCP, C. Diagnostic laparoscopy, D. HIDA scan, or E. Hepatitis titers. All right, so the answer to this is D, a HIDA scan. So this question requires you to make your differential and also determine what is most likely in that differential diagnosis. And what is most likely is biliary atresia. So why biliary atresia? Well, we have a direct hyperbilirubinemia. The direct bilirubin is elevated. It's more than 20% of the total serum bilirubin. We also have signs of biliary blockage of some sort, in as much as we have acolic stools and dark urine. We also have signs of that we have an alkaline phosphatase and a GGT that are elevated. This shows that we have a biliary pathology. So since we know we have a biliary pathology, and we also know that the faces are normal, which points us away from Alagille syndrome, we can do a HIDA scan because our most likely diagnosis here is biliary atresia, and a HIDA scan will help us visualize the biliary ducts. And so this should be performed first because it's not as invasive as the other tests. Also, if you have biliary atresia, it's going to be very difficult to visualize the bile ducts via the other MRCP and ERCP. Although MRCP might work, it's more expensive. HIDA scan would be best test. So biliary atresia is a progressive fibroinflammatory obliteration of the lumen of the biliary tree. There's a slight female preponderance. Symptoms early on, babies are probably going to be normal on delivery and discharge because they have the ability to get rid of their bilirubin via the mother. But within the first 2 to 3 weeks of life, as they begin to rely on their own biliary tract, they will develop jaundice, dark urine, and acolic stools. Failure to thrive and symptoms of portal hypertension will develop within a few months as you begin to have damage to the liver. The diagnosis, really no single lab can consistently differentiate biliary atresia from other causes of obstructive jaundice. However, we can exclude some things, like I said earlier on, with Alagille syndrome. Typically in those cases, you have an abnormal facies. But really, we're going to have a differential diagnosis here, and we need to perform tests. Like in most obstructive jaundices, the alkaline phosphatase and gamma-glutamyltransferase will be elevated, and the transaminases may be mildly elevated as well. Now, the best initial diagnostic step, in my opinion, when you suspect biliary atresia is to do an abdominal sonography. Now, I didn't include that on here. And the reason is because, no, I did. Never mind. Sonography is performed and it's negative for masses and cysts. Okay, good. I'm glad I included that on here. So the reason, in my opinion, that you want to do an abdominal sonography first is because in some cases you can have a cyst or something else compressing the biliary duct, and in that case you're going to get the exact same symptomology because you have a blockage of the biliary tree. So you're going to get similar symptoms. But in that case, the biliary ducts are fine, you just have something blocking it. Now, it would be great to know if that's the case, because then you don't have to do anything else diagnostically. You'll know that there's a choledochal cyst or there's extrinsic compression, and an abdominal sonography can tell you that very easily, and it's a very easy test to do. And like I said, you don't have to go on and do other things necessarily. Now, if the abdominal sonography is negative for cysts or extrinsic compression, then you need to be concerned about biliary atresia, in which the bile ducts are not developed appropriately, or you have this obliteration. And so the best test to do in that case is going to be a HIDA scan, which should show, in the case of a normal child, would show normal uptake and normal excretion. Okay, you'll be able to visualize your biliary ducts. In the case of a child with biliary atresia, there will be normal uptake, the liver is working fine, but there'll be diminished excretion because you have obliteration and inflammation of your bile ducts. The most definitive way to diagnose this is percutaneous liver biopsy, but you should definitely do the HIDA scan first. The treatment for biliary atresia is the Kasai procedure, also known as a hepatoportoenterostomy. It's very similar to a Roux-en-Y gastric bypass, except you're making the connections a little differently. This is the treatment of choice for biliary atresia. The results are best if the procedure is performed very early on. If it's performed later, you can have some hepatic damage, and so that can be problematic. An intraoperative cholangiogram is going to be performed first. This is the best diagnostic test for biliary atresia. Remember, though, you're going to do the HIDA scan. That's going to be to get your tentative diagnosis, and then you'll do surgery. And then the intraoperative cholangiogram will be performed while you're doing the surgery, and that really gives you your definitive diagnosis for biliary atresia. And if the results are consistent during the intraoperative cholangiogram, then you'll go ahead and perform the Kasai procedure during the same operation. Postoperatively, the baby will need nutritional supplementation. A formula with medium-chain triglycerides is recommended, and fat-soluble vitamins should be monitored because there's not going to be as much bile getting into the intestine right away, and so fat-soluble vitamins will be decreased in their absorption. A transplant is really the only other treatment choice available. So the Kasai procedure, like I said, is very similar to that Roux-en-Y gastric bypass. The only difference is you're not bypassing the stomach, but you are making a Y. So remember, in a gastric bypass, a Roux-en-Y gastric bypass, you're going to be stapling off the stomach and then taking part of the duodenum and creating a new hole through the stomach and into that distal part of the duodenum. On the other hand, when you're doing the Kasai procedure, you're going to incise part of the duodenum, but you're going to take that and you're going to connect it to where the biliary ducts are. You're connecting it to this sort of porta hepatis area. And then to complete your loop, then you'll take that proximal end of the small intestine and connect that to the distal part of the duodenum here. And so you make a Y. Question 24. A G2P1 mother delivers a term baby boy weighing 7 pounds 11 ounces. Apgars are 9 and 10. On day 2 of life, the infant has failed to pass meconium. On physical examination, there's mild bloating. Abdominal x-ray reveals a soap bubble appearance within the bowel lumen and multiple dilated loops of small bowel. Upper GI series is unremarkable. Contrast enema reveals the following. I'll show you a picture. Which of the following is the best next step in the management of this patient? So let's get the picture here. So here is your contrast enema. You can pause it here if you want. I'll come back to it after I read through the questions or answers. Sorry. A, diagnostic laparoscopy. B, sweat chloride test. C, N-acetylcysteine enema. D, duodenostomy. Or E, abdominal laparotomy. Which of the following is the best next step in this patient? Again, here's your contrast enema. You can pause it here if you want. I'll go back to the answer choices. Okay, so the answer to this one is C, NAC enema. So what we want to do is relieve the obstruction first. So we know we have a large bowel obstruction because there's this soap bubble appearance within the bowel lumen, which is likely meconium. Baby has failed to pass meconium, and then also we're going to have signs of obstruction everywhere proximal to that. So that's sort of the rule of obstruction, is that wherever there's an obstruction, all your other radiographic signs are going to be there and then everywhere proximal to that, because those areas are going to be expanding because of the back pressure. So in this case, you have an obstruction in the large bowel, so you'll have perhaps some large bowel enlargement, but also definitely the multiple dilated loops of small bowel. Since you do an upper GI series, it tend to be unremarkable because the obstruction's not there. You're not really going to see anything. You may see some dilation. But when you do the contrast enema, it should reveal this meconium that has not passed. And in the case of, we'll go on to talk about this. So in this case, this is Meconium Ileus, which is an impaction of meconium. And the reason this gets impacted is because it's overly thick and tenacious, and it's difficult for it to pass. Why do we get meconium that's abnormal like this? It shouldn't happen. Meconium should be not overly thick, and it should be passed. But in the case of cystic fibrosis, where you have an abnormal chloride channel, you're going to have thicker secretions. And that's the rule of thumb for everything in cystic fibrosis. You have thicker secretions in the lungs, you have thicker secretions in the pancreas, you have thicker secretions in the intestine early on. And so this is a manifestation of cystic fibrosis in many cases. And 13 to 17% of cystic fibrosis babies will have Meconium ileus. Now, on the contrary, a baby who has Meconium ileus is almost always going to have cystic fibrosis. And so this is cystic fibrosis until proven otherwise. The symptoms include abdominal distension, bilious vomiting, because this is an obstruction distal to the sphincter of Oddi. You'll also have failure to pass meconium, and then respiratory complications can result from severe distension. It's going to push the diaphragm up onto the lungs, and the baby's not going to be able to take a full breath. Best initial diagnostic test is an abdominal X-ray, which was performed here. That's always going to be the best test when you best initial test when you suspect an obstruction, which failure to pass meconium is a sign of obstruction. And that will reveal multiple loops of small bowel in a soap bubble appearance. And that soap bubble appearance is just the inspissated meconium. This should always be followed by an upper GI contrast study and a contrast enema. And the contrast enema will demonstrate a microcolon inspissated with meconium at the terminal ileum. So going back here, you can kind of see this microcolon back here. Not too good though. This isn't the best picture for that. The management can be done during the diagnostic enema, so you can use N-acetylcysteine added to the fluid. That helps dissolve the meconium, and this is successful in half of cases. When it's not successful, I think usually they will try twice. The pediatric gastroenterologist will try twice with the N-acetylcysteine or with the diagnostic enema for therapeutic means. If it's not successful, it's going to require laparotomy. And then, of course, these children should be tested with a sweat chloride test for cystic fibrosis. So that was an answer choice, but that's sort of a couple steps ahead of us. We need to diagnose the Meconium ileus and treat it first. So here's some more pictures. This would be what an X-ray would look like. Note your multiple dilated loops of small bowel. This is a better picture of the microcolon here. Now I want to differentiate here meconium plug syndrome. It has a similar name, but it's not the same thing. So in Meconium ileus, the meconium is abnormally thick, but the intestine is normal. It's just we have thick meconium because of the cystic fibrosis issue causing a thick meconium, and we can't pass it because it's so thick, and it gets stuck. With meconium plug syndrome, the meconium, on the other hand, is normal, but the intestine is functionally immature, and so you can't get the meconium out because the intestine is not working properly. And so the meconium will become backed up and it forms a plug. This is associated with infants of diabetic mothers, also associated with mothers who are on magnesium sulfate for something like preeclampsia or eclampsia. Differential diagnosis from Meconium ileus. On contrast enema, some of the colon may appear normal with inspissated meconium, whereas in Meconium ileus, the entire colon is going to be micro. So then Hirschsprung's disease is another differential. Typically Hirschsprung's affects the rectosigmoidal area. They both can cause failure to pass meconium. Best way to differentiate this, if you're suspecting Hirschsprung's, is an anorectal manometry or a rectal biopsy that will provide a definitive rule out or rule in if you're suspecting Hirschsprung's disease. Another thing that can help you suspect this when you do the contrast enema for the Hirschsprung's disease. A lot of times you'll see the transitional zone in the rectosigmoidal area. And for diagnosis of meconium plug syndrome, it's going to be a contrast enema again. Management for meconium plug syndrome is pretty much the same. So you can do during the diagnostic enema and N-acetylcysteine addition, and then that can dissolve the meconium, and ultimately the intestine will mature. If you're suspecting Hirschsprung's, you can additionally do an anorectal manometry, and as many as 10 to 30% of meconium plug cases coexist with Hirschsprung's disease. So you will probably want to add that on to your initial management as well. Very few patients will require surgery with meconium plug syndrome. Question 25. A primipara mother delivers a term baby weighing 6 pounds 4 ounces. Apgars are 7 and 9 at 1 and 5 minutes. On nursery examination, you note watery nasal secretions and a desquamating rash of the palms and soles. Which of the following is the best next step in the management of this patient? A. VDRL-RPR of serum and CSF. B. Culture of nasal secretions. C. FTA-ABS. D. Penicillin G. Or E. Acyclovir. Alright, and our answer to this is VDRL-RPR of serum and CSF. So our presumptive diagnosis here is congenital syphilis, and we suspect that based on these watery nasal secretions coexisting with a desquamating rash of the palms and soles. Of course, in practice, maternal history is always going to be useful. Typically, this will be a mother with a known history of syphilis. However, on the USMLE, you're not always going to be given that, so I want to give it to you here. The best first test to do when you're suspecting syphilis is always going to be a VDRL-RPR. This is your sort of your screening test, and then your more specific test is the FTA-ABS. Now you do that VDRL-RPR first, and you do it of the serum and the cerebral spinal fluid, because if there is syphilis in the cerebral spinal fluid, the child's going to be at risk for neurosyphilis, and so we need to know that right away. So we'll get that of the serum and the CSF. After that, you can do an FTA-ABS to confirm, but generally we'll just go right on to treat with penicillin G. We treat the exact same way, probably different dosages, but we treat the exact same way as we would for syphilis in adults. Now, if you have a CSF that's positive for syphilis, then you'll probably want to give a higher dosage of penicillin.